Okay, we all know, and I think this has already been said several times, surgery alone does not do the job. And there is relapse, local relapse or distant relapse, the rule in our patients, of course, depending on the stage of disease. And this situation underlines, again, the importance of integrating systemic therapies into the management of early-stage lung cancer. Now, there is a let's say, a adjuvant chemotherapy which has been established over the years, and as you can see here, the benefit of adjuvant chemotherapy is marginal of platinum-based chemotherapy, and I think look at the hazard ratio. I think this is clinically important by then see the improvement through new options. Hazard ratio of 0.89 for neoadjuvant and adjuvant application of chemotherapy. Now, having new options, I think we also have to improve our diagnosis, and in particular, talking about targeted therapies and immunotherapies, a better diagnosis as far as the pathomorphology and molecular biology is critical. And again, on the basis of approved, validated, standardized technology. And I think histology is critical, but also treatable molecular targets should be indicated, and also biomarkers should also be tested routinely. Now, this is the summary of all the new pivotal trials, which has assessed several new options in resectable, and also which led to approval of certain therapies. What we can say, we have about 4 adjuvant trials, and we have 1 neoadjuvant trial, and about 3 perioperative trials, which really are helpful in selecting patients now in resectable patients. Now let's go to AdAura. You already saw this picture. This is the adjuvant or osimertinib in EGF mutant tumors in resected and non-small cell lung cancer. And I think here is the overall survival benefit in stage 2 to 3A disease in the overall population. And I think the most important thing is that the disease-free survival benefit was seen irrespective of patients receiving adjuvant chemotherapy or not. And I think one important point is that adjuvant osimertinib can really make the difference as far as the influence of brain metastasis. And as you can see here, osimertinib leads to a clinical increase in CNS disease-free survival with a hazard ratio of 0.81. Now, ALINA, as also already mentioned, is the adjuvant study in ALK-positive non-small cell lung cancer. I think the design was clear: alectinib versus platinum-based chemotherapy, which was the previous standard. And what you can see here, adjuvant alectinib significantly improves disease-free survival. And on the other hand, early data suggests that adjuvant alectinib can prevent or delay CNS recurrence. Now, having new approaches, new options, it is also clear that we must look at the endpoints of the clinical trials, and I think it is and this has been already also mentioned previously, that there are some older endpoints, which are still very valid, survival endpoints, but also the pathological response plays an important role because of being prognostic and predictive. And we talk about the pathological complete response and the major pathological response, and I think the definition is listed below. Now, here is the summary of the immune checkpoint inhibitors. We are going now away from the targeted therapies. And as you can see, just reminding you that chemotherapy alone has a hazard ratio of 0.88 or 0.89. Here we are dealing with, in the adjuvant setting, with a hazard ratio of 0.66 or 7.3, or neoadjuvant again 6.3, or in the neoadjuvant following adjuvant, this is what we call perioperative, even better. So this kind of new approaches show that adjuvant EO following adjuvant CT improves disease-free survival. Current immunochemotherapy as neoadjuvant treatment prolongs also event-free survival, and perioperative EO combined with neoadjuvant CT prolongs event-free survival. Now, in the Pearl Keynote 091, adjuvant pembrolizumab versus placebo was assessed after adjuvant chemotherapy, and this trial already provided survival data, and as you can see here, pembrolizumab compared to placebo significantly improves disease-free survival in completely resected PD-L1 unselected non-small cell lung cancer. And here, this is it is the outcome of IMpower 0110. I think this is important because there are different approval in FDA and EMA. I think we in Europe have this agent atezolizumab only available for patients or for tumors expressing PD-L1 larger than 50%. And I think you can see that here in this PDL status by SP 263. So it is really clear that the most pronounced benefit of PD-L1 expressing tumors. So then comes to neoadjuvant nivolumab plus chemotherapy, checkmate 816. I think it is the chemotherapy versus chemo-nivo. And here also the concept has been approved by FDA and EMA, and the concept prolongs event-free survival and increases pathological complete response significantly. Benefit is maintained over time across all subgroups. But a very important, clinically important point is, if you look at the AFS by predefined subgroups, and there are poor responses to neoadjuvant nivo plus chemotherapy, and this includes stage, squamous histology, and low PD-L1 and low TMB, tumor mutation burden. Now, there is another study which deals with nivolumab in resectable non-small cell lung cancer in the perioperative setting, giving nivolumab preoperatively and as neoadjuvant and as adjuvant chemotherapy. And you can here see that this perioperative approach combined, as I said, both adjuvant and neoadjuvant, improves, again, event-free survival the benefit seems greater compared to neoadjuvant chemotherapy, immunotherapy alone, hazard ratio 0.63. And here are these subgroups included: stage 0.18, squamous 0.46, and PDL1 0.73. So it makes sense to combine neoadjuvant and adjuvant nivolumab, at least according to Checkmate 77T. Now, this is also important that the rule of receiving a pathologic complete response, and here in this Checkmate 77T, they showed us that the pathologic complete response plays an important role as far as extending the event-free survival. Now, keynote 671, it's the perioperative pembrolizumab combined with neoadjuvant chemotherapy. And here, the overall survival is shown in perioperative pembrolizumab does not only significantly improve event-free survival, pathological complete response, major pathological response, but also overall survival. I think this agent is not available for this particular situation in Bulgaria. I'm not sure about that. Now we have also the perioperative durvalumab information from the AGAIN trial. And here, this approach also improves significantly event-free survival across most subgroups, and the AFS benefit is maintained with time, as you can see on this plateau-forming curves. Now,
excuse me, Professor Manegold. I'm sorry, but we're running quite a bit late.
No, I'm not. 15 minutes.
Okay.
So durvalumab combined with neoadjuvant chemotherapy is associated with significant higher progression, pathological complete response, as you can see here. So toxicity, it's important that the approach has no detrimental effect on the completion of neoadjuvant CT or surgery. Now the observations from cross-comparison EO trials. Efficacy is higher for perioperative compared to adjuvant or neoadjuvant EO alone. Efficacy is higher for concurrent combination CT EO compared to EO monotherapy in the neoadjuvant setting. Neoadjuvant CT EO leads to a better immune response and an increased T-cell clonal expansion, intact tumor and lymph nodes. Efficacy is higher for sequential CT followed by EO compared to EO mono in the adjuvant setting. Neoadjuvant approach is associated with higher treatment compliance compared to adjuvant approach. EO poorly works in tumor harboring oncogenic drivers, low immune response rates, and seems less beneficial in low PDL TMB expression tumors. Now, how to select on the basis of this information we have? There is no head-to-head comparison. There are only cross-trial comparisons. So in mutant tumors, I think we heard that EGF in mutant tumor approved adjuvant osimertinib is recommended, and preoperative chemotherapy followed by resection and TT is also an option. In ALK mutant tumors, alectinib is recommended, but also preoperative chemotherapy followed by resection and TT is also an option. And in mutant tumors without approved TT, enrollment in clinical trials is one option. Upfront resection followed by CT and IO is also an option, in particular if the risk is high as far as inoperability and unresectability during this treatment phase. And neoadjuvant CT followed by resection is also an option in cases where we do not expect a high risk of inoperability or unresectability. Now, in non-mutant tumors, we go for the PDL expression and the TMB. If this is high, we expect a high EO response, and there's perioperative IO combined with neoadjuvant CT is recommended, and in tumors PDL low and TMB also low, with a high expectation of low response, enrollment in clinical trials, neoadjuvant CTO followed by resection is an option, upfront resection followed by adjuvant CT is an option, and defined CT RT, radiotherapy followed by consolidation IO in borderline resectability cases is probably the best option. Now, in summary, and I think this is, in my mind, very important, surgery remains the backbone in the management of resectable tumors. Therefore, maintaining medical operability and surgical resectability during multimodality approaches are critical. Advanced radiological imaging and molecular biological reflex testing for oncogenic drivers and biomarkers have become a critical part of precise staging and diagnosing, leading to improved therapies. Neoadjuvant, adjuvant, and perioperative IO as well adjuvant TT have been approved. Individual treatment decisions, however, are based on cross-trial comparison rather than head-to-head comparisons. Adjuvant approved TT is recommended in mutant tumors harboring treatable molecular targets, and perioperative IO combined with neoadjuvant CT seems most beneficial for non-mutant resectable tumors and is considered current standard of care. Thank you very much for your attention.